Parita Johnson is a mother with a mission. That mission, to keep her children healthy. On Bioko Island in Equatorial Guinea, that's not easy. Malaria has ravaged this West African country for thousands of years. For Parita, malaria became personal when her young son Sebastian became ill.
Siempre se enfermaba y incluso le subía convulsiones.
He got sick frequently. He even had convulsions once. And at that point, I was really frightened. It is horrible to see how malaria affects your child's brain.
Dr. Enrique Iyanga has heard hundreds of stories like Parita's. He's treated many patients with malaria. Some did not survive. But today, Dr. Iyanga has something he didn't have when he started seeing malaria patients: hope.
Yo que soy médico, estoy en el terreno y...
I'm a medical doctor, and I work in a field clinic here in Riaba. And I know that I've seen the malaria prevalence rate in our district come down to less than half from what it was a few years ago.
In 2003, more than 45% of Bioko Island children under the age of 15 were infected with the malaria parasite. By 2012, that rate had dropped to 13%. This is the story of what's happened on Bioko, and why this island, about half the size of Rhode Island, is at the forefront of malaria control worldwide. At the London School of Hygiene and Tropical Medicine, Imo Kleinschmidt is an epidemiologist and biostatistician specializing in malaria.
It is still one of the major diseases in the world. It is a huge killer, particularly of children in countries where transmission is high.
Eradicating malaria has been the life's work of another researcher, Janet Hemingway. She is director of the Liverpool School of Tropical Medicine and professor of insect molecular biology.
Malaria clearly is still a problem. We used to be able to say that every 5 seconds a child dies of malaria. Things have improved, and that's great. But still, every 30 seconds a child is dying of malaria.
According to the World Health Organization, there were 207 million documented cases of malaria in 2012. 627,000 people died, most of them children in Africa. Some experts believe the numbers are much higher.
Yet it is a disease that is totally preventable and totally curable. So every malaria death is a tragedy because it could have been avoided.
Janet Hemingway and Imo Kleinschmidt are advisors to the Bioko Island Malaria Control Project. Begun in 2003, the project is funded and organized by the government of Equatorial Guinea and private sector companies working in the country. Kleinschmidt is the project's senior epidemiologist.
Before we started this project, the under 5 mortality rate was 150 per 1,000 births. That means out of every 1,000 children born, more than 150 wouldn't make it to the 5th year of age.
One reason for such high numbers? Bioko Island is a perfect breeding ground for several types of mosquitoes that carry the malaria parasite.
Anywhere where you've got a lot of water, which are good breeding sites for the mosquitoes, where you've regularly got quite high temperatures but not too high, and where you don't get long periods of drought, you're going to get the mosquitoes thriving, and a temperature where the mosquito parasite life cycle aligns almost exactly.
On Bioko Island, the malaria parasite found other allies. Poverty, a weak medical infrastructure, and lack of health education help the parasite get inside of people's homes and go undiagnosed in their bodies. In 2003, malaria was as virulent on Bioko Island as anywhere in the world.
At that time, you could see in hospitals a lot of children that were very sick because of malaria. There wasn't any awareness in the community, and sometimes children were taken to the traditional healers, assuming they weren't suffering from malaria.
Then a new factor entered into the malaria equation. In the late 1990s, oil and gas was discovered in the Gulf of Guinea.
The entry of the American oil companies confirmed that the energy opportunities here were profitable, and also that they were willing to invest to develop them.
To develop the fields and build a proposed gas processing plant, the energy companies needed healthy, productive workers.
We had a very aggressive plan to expand it so we'd have a business that will last for at least 20 or 40 years. And by doing that, we became the largest employer on the island. So very quickly, we started looking at our sustainability in the country, and malaria was clearly, the biggest challenge that we would face as an employer, but also the community has been facing.
The energy companies brought three weapons to the fight against malaria: money, a long-term outlook, and an obsession with gathering data to make decisions.
The negotiations started with a goal of finding out how these companies could support the country in the fight against malaria. This is the way the Project of Malaria Control was born on the island.
I think these partnerships in Equatorial Guinea are very positive. In some countries, the partnerships are the ones making the decisions. But in Equatorial Guinea, our partnerships are based on mutual agreements. Contributions come from both parties, but the government defines the strategy to be followed.
A nonprofit organization, Medical Care Development International, was hired to implement the project.
When we began working in the late 2003, early 2004, malaria was the #1 killer of children and pregnant women on the island. It accounted for about 35% of all recorded mortality, and it was the #1 source of morbidity or illness on the island. We conducted a number of baseline surveys at the time, and the evidence from those surveys indicated that on average, every person on the island suffered at least one case of malaria per year, and among the child population, that could be 2 or 3 cases of malaria a year.
The Bioko Project's goal was to reduce malaria transmission by breaking the cycle of mosquitoes biting and infecting new victims. To reach that goal, the project focused on spraying the inside walls of homes with insecticide, a strategy very different from the malaria prevention efforts of the World Health Organization and the worldwide Rollback Malaria Initiative.
When the project started, it was originally predicated on one single intervention, and that was indoor residual spraying. It was one of the objectives of the project to demonstrate that indoor residual spraying was an effective means of controlling malaria in a hyper-endemic area like exists in Bioko.
Some doubted this approach. The effectiveness of indoor spraying had never been proven in sub-Saharan Africa, where there was year-round malaria transmission. Most malaria control programs around the world made insecticide-treated bed nets the primary disease prevention tool.
The first year there was the biggest impact of the project. This is quite common in many malaria control. The first 2-3 years there was a significant decrease of mortality, morbidity, and malaria transmission.
People want to know when the sprayers will pass by their homes. They say they were here 3 months ago and the mosquitoes are starting to come again. They know the program helps them prevent mosquito bites and getting infected. Infant mortality has been reduced, and people are aware that it is because of the program against malaria, especially on Bioko Island, and they're willing to participate.
The initial results were so encouraging that President George W. Bush, in his important President's Malaria Initiative, endorsed the Bioko approach of indoor spraying in 14 sub-Saharan African countries, starting in 2006. At the same time spraying was taking place, the project team also focused on improving the diagnosis and treatment of malaria.
Malaria is known as the great pretender of all diseases. We see a child who presents with a fever and looks like he has a cold, and his mother will say he's been vomiting for days, and he may indeed have a cold, but when we look at the thick blood smear, he may also have high levels of the malaria parasite.
There was another problem. The malaria parasite is highly adaptable. It had developed a resistance to chloroquine, the primary drug used to kill it. With the support of its corporate partners, Equatorial Guinea became one of the first countries in Africa to implement a new artemisinin combination drug therapy. It also distributed thousands of rapid diagnostic tests. Many lives were saved. The malaria caseload at government health facilities went from 55,000 cases in 2005 to 14,000 cases a year later. Hopes were high for a victory over malaria. But to know malaria is to know disappointment. And Dr. Stephen Hoffman knows malaria.
The level of malaria transmission on Bioko Island before the Bioko Island Malaria Control Project went into place was as high as it is anywhere in the world, and much higher than most places in the world, and much higher than most places in Africa. That's the face of malaria to me when I look at those numbers. It's not just numbers. It's the children that I've seen who died of malaria that I couldn't do anything about.
From 1987 to 2001, he was director of the malaria program at the Naval Medical Research Center. Later, at Celera Genomics, he organized the effort that sequenced the genome of the mosquito responsible for most transmissions of malaria in Africa. About the time the Bioko Malaria Control Project was being contemplated, Hoffman was launching a company called Scenaria to create a malaria vaccine.
Our vaccine is completely different in terms of what we're aiming for it to do compared to the other approaches to malaria vaccine development. There is no other approach that's demonstrated it's possible to have a vaccine that could prevent infection, disease, and transmission.
His approach was based on a study on mice done in 1967. It showed that if you exposed an infected mosquito to radiation, it damaged the parasite's DNA. That made it impossible for the parasite to replicate once it has entered the bloodstream. It also gave the mouse's body enough time to produce an effective immune response. Human follow-up studies in the 1970s also showed that immunization against two key malaria parasites was possible if you were willing to be bitten by more than 1,000 irradiated mosquitoes. Translating that information into a real-world application presented huge challenges. It meant breeding bacteria-free mosquitoes and removing the malaria parasites from the mosquito salivary glands. Then the parasites had to be purified and cryogenically preserved. But by 2006, against long odds, a vaccine suitable for human testing was nearly ready. So were the doubters. One malaria expert told the New York Times, even calling it a vaccine is a compliment. It has no chance of offering protection. It is like Captain Ahab in the movie trying to kill Moby Dick with his knife. Back on Bioko Island, doubts were also surfacing about the effectiveness of indoor spraying.
When the program first started, they first started using pyrethroid insecticides, and we then discovered that there was resistance coming through to those pyrethroids in one of the major mosquito species. So we then had to work out what new insecticide we should actually come in with.
Malaria is a moving target, and malaria control is a moving target. Both the vector, the mosquito, and the parasite are highly adaptable, and they change when they're presented with a consistent control intervention over a long period of time. They adapt.
In our fight against malaria, we can't start an activity yesterday and then quit it today. It has to be a constant fight, a continuous fight.
History supports that assessment.
A very frequently cited case in point is the situation that occurred in Sri Lanka in the 60s. Sri Lanka launched a national vector control program based on the use of DDT for indoor residual spraying, and they achieved dramatic results. From 1960 to 1963, they went from 3 million cases down to 18 cases in 1964.
But with elimination of malaria in sight, support for indoor spraying waned. Malaria and mosquitoes quickly regained their edge. By the time spraying was reintroduced, mosquitoes had developed a resistance to DDT. Within a year, malaria was back to being the #1 source of illness in the country. On Bioko, project leaders were determined not to make the same mistake. When routine monitoring identified resistance to the pyrethroids insecticide used in the first year of spraying on Bioko, a substitute was introduced. It cost 5 times as much and required 2 rounds of spraying each year instead of 1. In spite of the willingness of the partners to finance the increased costs, within a few years, it was clear how difficult it was to sustain high levels of spray coverage. Indoor spraying alone was not sufficient to eliminate malaria on Bioko Island.
In the fight against malaria, spraying isn't enough. First of all, spraying has been done on the island for a very long time. The community is familiar with it, and frankly, they get tired of it. They want to see other strategies used also, because they've heard about what other countries are doing. Like, for instance, the use of mosquito nets.
With added funding from corporate partners, more than 100,000 insecticide-treated bed nets were distributed by Red Cross volunteers.
In 2008, there was a massive distribution of mosquito nets, which meant that the use rate for these nets was really high, about 76%. This really made a big impact on malaria prevention.
Health education was also beefed up.
Whenever a patient comes to our health center, they realize that everything we do happens after they go through our health education activities. We focus on how to prevent malaria. We do this every morning.
After 5 years, the project was a proven lifesaver. The number of mosquitoes infected with the parasite was down 95%. One species of malaria-carrying mosquito had been eliminated. Deaths in young children had declined by 2/3 in 4 years. In 2007, Patrick Katcher of the U.S. Centers for Disease Control said the Bioko Project was better positioned than any such intervention program I have seen in action on the African continent. Along with the accolades came attention and money.
The Global Fund project, implemented in 2007, involved a contribution of $26 million to the government of Equatorial Guinea to carry out malaria control activities in the continental region of the country.
On Bioko Island by 2010, most of the tools needed for a long-term fight against malaria were in place. Thanks to oil and gas revenue, the government had more money to fund malaria control. National health initiatives were expanded. Malaria control officers were trained. Reliable data were collected, and there was an expanding group of outside malaria advisors.
In the last 10 years, things have really improved. The political strategy in the country, the involvement of the government. There is more funding available for the activities of the Malaria Control Project. Accessibility of health centers has also improved. Each mother knows that if her child has a fever, she needs to take them to the hospital. They know they are going to get tested for free and will also receive the malaria treatment free of charge.
Once again, confidence and hope were growing on Bioko. While malaria flourished amid poverty, it adapted well to affluence.
Another major challenge that has occurred, paradoxically, has been the result of the economic boom that has taken place as a result of the oil sector in the country. And what's happened is that there's been a huge growth in housing. And the core element of our strategy is to spray the inner walls of all houses. And so there have been 3 separate times over the last 10 years where the scale of the program and the budget for the program have had to be adjusted because of this huge growth in housing.
In fact, the number of houses had nearly doubled since the project began.
The other big challenge we've faced, and is becoming more and more a problem as we move towards eliminating malaria from the island, is that there's a continuous inflow or importation of malaria from the mainland. where prevalence rates are as high as 70%, so where 70% of the people are infected with the disease. So there's a lot of traffic going back and forth between the island and the mainland.
After several years of scaled-up, integrated control measures, the prevalence of malaria infection changed. Once uniformly high across the island, infection rates fell to very low levels in some areas, but remained persistently high in others. Efforts to wipe out mosquito breeding sites and kill mosquito larvae became an important strategy in these hotspots. A pilot program in Punta Europa trained residents like Parita Johnson to be community malaria agents.
I talked to them about my daily fight against malaria. I mentioned the methods that we are using nowadays, like spraying and mosquito nets, and also the need to keep a clean environment.
With all these steps, there was a decrease in malaria cases. Then in 2013, the disease hit back hard. The number of infections and cases treated at public health facilities increased.
We investigated the reasons why this year there was an increase in comparison to a positive trend. In the last 3 years, there was a declining trend. There are several reasons. One is malaria is not, the transmission level of malaria is not stable. It changes year by year. There are climatic factors, rainfall, population movements. So this can be a contributing factor. It's part of the epidemiology of malaria.
Everyone agrees on several things. The control measures practiced on Bioko may keep malaria from rebounding. They can even lead to further reductions in morbidity and mortality. But without a vaccine to interrupt transmission, the prospects of elimination are slim. In 2007, the Bill and Melinda Gates Foundation gave Stephen Hoffman a $29.3 million grant to move his malaria vaccine research toward clinical trials. Those initial trials fell far short of expectations. Scenaria was denied another infusion of Gates Foundation money. Believing that the trial protocol was the problem, not his vaccine, Hoffman went looking for funding and places to conduct more trials.
About 4 years ago, one of our senior staff, Dr. Peter Billingsley, was reading about the Bioko Island Malaria Control Project and thought, this is a perfect place for us to work. This would be the perfect place for us to demonstrate that our vaccine works. Why is it a perfect place? It's an island. You want to show that you can use a mass administration campaign in a geographically defined area to wipe out malaria. What better place than an island?
Funding from the Equatorial Guinea government and its corporate partners helped Scenaria finance a new clinical study to be conducted on Bioko Island. With other funding sources, similar trials will be conducted in Tanzania, Mali, Europe, and the US. Even more important, a trial in 2012, conducted by the National Institutes of Health in the US, finally gave Hoffman the results he was hoping for. 100% effectiveness in the vaccine group that received the highest dosage. No other malaria vaccine has come close to those results. Vaccine testing will keep Bioko Island center stage in the war on malaria.
In this case, Equatorial Guinea has been seen as a country with a big opportunity to help our own country and our population, yes, but also an opportunity to be able to help all of Africa.
Researchers like Janet Hemingway believe Bioko will be an ideal location for vaccine trials.
It's got to be the best data set that we've got for any malaria control program anywhere in the world at the moment, because it's been very well set up, it's been very well run, and the monitoring and evaluation has been taken really seriously. So we can actually track what's been happening over time. The level of detail that's been collected in other malaria programs in most parts of the world just wouldn't even have shown up.
I think Equatorial Guinea has the circumstances and the political will, along with the will of many others, to eliminate malaria.
The potential for a vaccine has once again raised hopes on Bioko. But with the prospect of mass inoculation at least 5 years away, the daily fight continues.
It's not easy to do this. Lots of people think going into a relatively small island, it ought to be relatively straightforward to eradicate malaria from it. And we've all learnt that it's not, because we're dealing with a disease that has been in man for many thousands of years.
Now in its 10th year, the Bioko Project is working on a new 5-year plan. A lot has been learned.
There are a number of keys to a successful project, at least based on our experience, and I think the number one key is community involvement, community participation. You need community involvement at multiple stages of the malaria control program.
No one knows this better than Parita Johnson. She tells anyone who will listen.
I think Equatorial Guinea will one day be able to say, we had malaria, but not anymore. But we need to cooperate. We need my contribution and also yours.